Welcome to the MPRO Road to Defeat CAUTI. Your host will now begin.
Thank you. On behalf of MPRO, Michigan's Quality Improvement Organization, we want to welcome you to today's webinar, Roadmap to Defeat CAUTI. I'm Diane McKegg, the project lead for HAI with MPRO. I also want to thank Michelle Norcross over at Michigan Health and Hospital Association for her assistance in facilitating our webinar speaker for today. This webinar is sponsored by HAI 10, which is a consortium of 10 quality improvement organizations dedicated to the eradication and prevention of health care associated infections in the hospitals. Partners include our stakeholders in Idaho, Illinois, Indiana, Iowa, Kentucky, Michigan, Ohio, Oregon, Washington, and Wisconsin. We'd like to remind you that this call is being recorded, and at the end of the webinar, please complete the polling questions that will appear on your computer screen. Also, we have a chat functionality that we'll be monitoring if you have additional questions throughout the presentation. I'm very pleased and honored to introduce our speaker for today. Dr. Mohamad Fakih is a professor of medicine at Wayne State University School of Medicine, Detroit, Michigan. He is board certified in internal medicine, infectious diseases, and quality. He also has a master's degree in public health from the University of Michigan. Dr. Fakih is a hospital epidemiologist, infectious disease faculty, and medical director of infection prevention and control at St. John's Hospital and Medical Center in Detroit, Michigan. He is the national infectious disease physician leader for Ascension Health, a system comprised of more than 100 hospitals. His main research focus is reducing risk of patient harm through evidence-based practice, with a focus on indwelling urinary and vascular catheters. Dr. Fakih's contributions include the creation of a comprehensive toolkit to promote the appropriate utilization of urinary catheters in the hospital setting. He is one of 2 national key faculty members to reduce unnecessary urinary catheter utilization in the acute care setting throughout the country for the On the Cusp Stop CAUTI project. He also completed a toolkit to reduce unnecessary urinary catheter placement in the emergency departments, and many, many more accomplishments. At this time, please welcome Dr. Fakih as we share, learn, and improve together. Dr. Fakih?
Thank you very much, and it's an honor for me to be on this call today and present. So I'm going to talk about the roadmap to defeat CAUTI. And before I talk about CAUTI, I think I want to make sure that I point out that urinary catheter harm, I think, is much more important than CAUTI by itself. And for teams that have been working with Partnership for Patients or other hospitals that have been trying to reduce harm for patients, we should consider this as a patient-centric issue rather than an infection, one of the infections that may happen to a patient in the hospital. So as you see in yellow, a lot of events that are looked at with Partnership for Patients relate to the catheter. So if we give a medication that causes urinary retention, it may end up leading to the urinary catheter use and potential harm. If we have a catheter that's not needed and kept in a patient for a prolonged period of time, then it can lead to CAUTI, can lead to pressure ulcers because of immobility, or even trauma to the urethra, patient discomfort. Immobility, in turn, may lead to increased risk for venous thromboembolism, such as DVT and PE, and falls. So it's not just the infection related to urinary catheter. It's multiple issues that may be tagged to that catheter and causing patients' outcome to be worse. So our objectives today are to describe the approach to CAUTI reduction in the hospital setting, and then describe how we synergistically can work together as departments and disciplines so we can get the best outcome to our patients. And again, having a patient-centric approach, and how we engage the staff so they'll have buy-in and hopefully ownership to the work. And then I'm going to address some of the issues that will, some of the barriers that will be seen with our efforts. And at the end, let's say we're doing everything right and our numbers are not moving, what could be some of the issues that we encounter? I try to see this as a know your device or know your catheter. So this can be, in fact, looked at for the central line, for the vent, for the peripheral IV, but here we'll talk about the urinary catheter. I think it's quite important to know when the catheter is needed, so the indications, when would I put a catheter in? Second one would be, if I'm going to put a catheter in, am I putting it correctly? Proper insertion technique. The third point would be the catheter is in. Okay, during the utilization of that catheter, are we making sure that the proper maintenance is there? And the last thing is, when the catheter is no longer necessary for the patient's care, are we removing it as soon as possible? So these are the four different items I think we need to look at, and I'm pretty sure a lot of you have looked at these issues. I'm going to review them very fast. So initially, know when you need it. So it's quite important when we say, okay, use the catheter when it's based on appropriate indications, to have clear identification of what the indications are. So if we're not very clear in our hospitals, in our institutions, what represents the appropriate indication for use, how do we expect our healthcare workers to comply with the appropriate indications? So that's the first step. Have agreement of key leaders on the indications and have the institutional guidelines. And it can't be just adopting the HCPCS guidelines, which I'm showing in this slide. Now, the HCPCS guidelines I'm going to go through them. There's 6 main categories, and basically they make quite a bit of sense. They're based on expert consensus, but they're the best guidelines we have so far. Very, very recently, this is about a couple of weeks ago, the SHEA 2014 update almost updated the same guidelines. The same items were listed. The only one that was not listed, I think, for immobility related to trauma or risk of displacement, fractures, stuff like that. But basically, it's almost a copy of the CDC HCPCS guidelines. So part of it is perioperative use and selective surgical procedures, output assessment in patients in an ICU, that, if there's a need for hourly assessment. If there's no need, then you don't use it. Management of acute urinary retention and obstruction, assistance in healing open pressure ulcers, so, risk of someone who's incontinent and risk of deterioration of a wound, so in the same area, then it is an indication. Incontinence alone is not. In fact, it's something that we discourage using catheter for. And as an exception, at patient request to improve comfort and of life care. So stuff in red here, this is the ED geriatric guidelines, very recently out. You may not have seen it, but if you've seen it, I can give you an update. So these are ED geriatric guidelines. They had multiple items in these guidelines, including the urinary catheter use. And there were some acceptable indications, but others that were very controversial and of I'm not going to say worrisome, but they need quite a bit of clarification. What the good news here is that the CDC and other leaders in our country have engaged the authors of these guidelines, and they are working with them on my understanding, an erratum to clarify these indications. So there would be hopefully an addendum to these guidelines. Hopefully it will be in concert with the national guidelines, so we won't have any confusion. And what's controversial about these guidelines? So one item is very close monitoring of urine output and patients unable to use urinal at that time. We see this as a convenience issue, so hopefully not having this as part of the utilization guidelines. And another one is patient too ill, fatigued, or incapacitated. A lot of patients are incapacitated or fatigued, and this is not an indication to place. Recent surgery, they did not explain what kind of surgery, and management of urinary incontinence on patient's request, and this is a no-no for us. So I just want you to know, if someone shares these guidelines with you. There would be something coming up to better define these guidelines, and I suggest not to adopt these guidelines. In fact, I worry about them being used for geriatric population. I think we have two guidelines, the CDC HICPA guidelines and the SHEA guidelines just came out, that would be the best guidelines right now to use. So we spoke. So I spoke about the guidelines. And what are the appropriate indications? Hopefully, if we know what the appropriate indications are, then we will avoid placing catheter when it's not needed. And where would the catheter be placed when it's not needed? A large proportion of our patients is admitted from the emergency department. More than half of our patients, depending on the hospital. The other place where they place a lot of catheters is the operating room. So I'm going to show you some data. So first, intervening in the ED or the OR can affect all the units in the hospital. For example, if you're getting in the ED, the admissions, more than half of the admissions to the hospital, and they can go to the ICU and other units, dealing with the ED and reducing utilization can affect the whole hospital utilization of catheters. So that's a huge impact, and it's only one unit that you're targeting. Similarly, in the OR, if a patient does not need a catheter and we don't put the catheter in, then the patient goes to the surgical floor and the utilization is much lower, and you don't have to deal with the post-operative day 1 or day 2 for removing the catheter. So it's quite important to address appropriateness of placement in the each unit. How do we improve the urinary catheter use in the ED? Again, I don't want to be redundant, but this is what it is. Establish clear guidelines for urinary catheter insertion in the emergency department, and then have champions. The physicians and nurses are very important. You cannot just use a physician champion or use a nurse champion and forget about the other group. And the interesting part about the ED department is that there is a team collaboration between physicians and nurses, and the roles sometimes are quite ambiguous, and there's quite a bit of independence of nurses in the ED. So quite important to have both champions, physician and nurse champions, and nursing buy-in. I'm going to discuss with you in a very short manner a pilot work at Ascension Health. 18 emergency departments worked in 2012 on reducing urinary catheter use in the ED, unnecessary urinary catheter use. They started with different baselines, but what we've seen is up to 50% drop in placement of newly placed catheters and increased appropriateness of use. The average was about 30-some percent, so reduction in catheter use by a third. And if you see here from the slides, newly placed catheters in the emergency department started with about 9%. We went down to 6%, and at the end with sustainability, this is within 6 months, about 5.4%. Now, when you look at appropriate reason for placement, it also went up from 70s to the 90s. So very impressive, a huge opportunity to reduce harm to our patients, infectious and non-infectious harm. This was published very recently in the Annals of Emergency Medicine, and it's open access if you want to review that study. ED physician and nurse champions. So how do you choose them? You need someone who really cares about improving the catheter use in the ED, someone who really believes that the catheter is not a harmless device, someone who believes that the catheter may hurt people, and feel that the catheter should not be placed unless there's a very clear reason, appropriate reason for placement. These physicians and nurses should be respected by their colleagues, should be looked at as someone, a partner at the same time, someone who will, if that person, she or he, says something, that it will be taken as something positive and something to emulate. So in the ED, find champions that will help you disseminate the work with their peers, and these champions will, with time, reinforce the message that just place the catheter when there's an appropriate indication. What about the OR? OR is so important to engage the surgeons. A lot of stuff we used to do 20 years ago, we may not see need for it right now. And if we have plans that have not been reviewed over the years and continue to be used, maybe we need to re-review, let's say, some standing orders for surgery. Talking to surgeons and asking the question, what kind of surgery would you think a catheter would be needed? So is a hernia surgery something that you need a catheter for? Or colon surgery? So just have very clear, questions and answers from the surgeon, from you to the surgeons and the surgeons giving you feedback, and hopefully have some standardization of what you do in the OR. And let's say the answer was yes, we'll need a catheter, and you agree as a facility. Then the other question would be, well, when can we pull that catheter out? And if we're able to pull that catheter out in the OR before that patient wakes up, that's great. And if not, maybe in the PACU, post-anesthesia care unit. So you don't have to, this way you would not have to make it more of a chore for those that are on the floor dealing with the catheter need. You take care of it even before they reach the floor. So we spoke about, place it only when it's needed, and now the next step would be know how to place it. So proper incision technique is very important, and the first thing that you need to make sure you have is the kit that you're using for placement to be all-inclusive. So you don't have to go from, one place to another to get all the elements. This will improve your compliance with the placement of that catheter. Use the appropriate catheter size and all the components being there. So this is a checklist that I've made, and it's it may remind you of the central line checklist, and it has 5 elements. It's just to make sure that whoever is placing the catheter is compliant with the proper insertion steps. This may be used when you're looking for, if you're evaluating competencies of your staff. Okay, so we spoke about know when you need it, know how to place it, and now what about how to care for it or maintenance? Closed system is number 1. You should not open the system. And then make sure that there is no obstruction or issues with the collecting system draining well. Bag under the bladder so gravity will go down, and we should not have twists or kinks. So the insertion and maintenance is a nursing component mostly. Physicians are usually not as involved. You can consider periodic audits. And the last point is know when it's no longer needed. So we started this in 2006, so we've been very lucky at my institution. We worked on the urinary catheters way before many other hospitals. The pilot study, which was in 2006, we showed a reduction of 45% of unnecessary catheter use. The Michigan Collaborative, which is our state, 163 units, very similar to what we've done earlier. We showed we showed 25% reduction in use. What is interesting about these 2 studies is that they include non-intensive care units. The Michigan experience here, you see that it was 25% reduction in use and 30% increase in appropriate indications. Very, very nice, proof that this intervention works. The external validity here is very obvious. So it was generalizable. So what would we suggest in the non-intensive care unit? First, daily evaluation of need. It has to be part of the daily nursing assessment. Similar to when if I'm a nurse and there's a medication, let's say aspirin or atenolol, medication that you give to a patient every day, why don't we assess for device need every day? in fact, it's probably more risky than giving some of the medication or not giving a medication every day. So this is how we should think about it. It has not been on the radar screen for a long period of time. And provide feedback, on catheter use over time to the units involved. So what we've done over time at my facility, we have looked at point prevalence on Tuesdays and Thursdays and gave feedback to any unit that increases their utilization by a certain percentage. What about the ICU intervention? So we spoke a little bit about the non-intensive care units. ICUs have been struggling all through the country. It's been very tough, to move the numbers, whether it's utilization or CAUTI rates. I think at the ICU, we need to also have a mechanism every day for assessment of the urinary catheter. If you have a closed unit where you have an intensivist that rounds on everyone, it will be very important during multidisciplinary rounds to have the assessment done and directly remove the catheter. If there is no multidisciplinary rounds and it's an open unit, it may be a little bit harder. We do have some suggestions about how to address this. And another thing that's very important about the intensive care unit, in the intensive care unit is usually your utilization is about 50%, let's say. Some units, 80% utilization of urinary catheters. You go into the non-intensive care unit where the utilization is about, nationally it's about, I think, 17% right now. And my facility is averaging into an 800-bed hospital. For the longest time, I'm going to show you numbers, 12%. I mean, we dropped from 18 to 12%. And in fact, the very recent point prevalence, we were about 10%. So when you're talking to, about a prevalence rate 4 times higher than another unit, and then you're sending them to that unit, then it makes quite a bit of sense to evaluate the need before they're leaving the ICU and removing the catheter before they leave, so at exit. And as far as, removing catheters that are no longer needed, so you can always think about the ED. Even if you place a catheter in the ED initially because someone has pulmonary edema, they're going to the ICU, and then you diurese them and they're not going to the ICU anymore, they're going to the floor, maybe that catheter could be removed in the ED before they leave. Or the same thing, I mentioned this before, you put it for a surgery and then it's not needed, so after the surgery, remove it before they exit the OR. So what's the best approach? This is my wish list, a multi-departmental, multidisciplinary approach where you work in an ICU on evaluating the need on admission and continued need daily, and it will be part of the daily routine of the nurse. But also in the ICU, the OR or the ED, prevent placement as, for catheter is not needed. And before exit from these units, make sure that if there's a catheter that is, there's no reason for it to be present, pull that catheter out. So as you see, we can synergistically work together as departments to reduce utilization. What about engaging the staff in the work? We talk about building the team, so we have the champions, the supporters, and the leadership. And let me describe a little bit each one of them. The champion is similar to what we talked about in the ED. That person needs to be motivated, engaged, and respected by others, and has passion towards improving safety. The roles or functions of that champion are to promote the best practices, so using the Foley when it's needed, identify any barriers and try to figure out the solutions with the partnership with other stakeholders, and provide performance feedback to peers. That person will be accountable, but also will promote accountability at the unit level. So that role is not an easy role, and you have to have someone who's not just assigned that role, but someone who really likes to do it. This is something that we shared with Ascension Health Hospitals. In fact, it's been a year and a half ago, and it describes how a champion can function and how you can have supporters to that champion. So that champion cannot do all the work alone. She or he needs to have support by the stakeholders that are affected by the Foley catheter. So if you remember my first figure, of this presentation, the urinary catheter harm is not just infection. So think about all the stakeholders. Think about that urologist who's called at 2 a.m. in the morning because a catheter was placed on a patient and then caused hematuria and had to come to the hospital. And that urologist gets really upset because this is a horrible damage to the urethra. Think about a wound ostomy nurse with pressure ulcers because that patient who's very debilitated, had a catheter in, and now the patient is not able to move around and developed a sacral ulcer. Think about let me think about. There's so many others. Think about length of stay for a case manager. So I'll give you some examples about physicians, and I put the physicians' examples here, but there are also other slides that I have for nursing and ancillary services. So it's not just to say physicians are the supporters, it's all of us. So the infectious disease specialist will worry about the CAUTI, catheter-associated urinary tract infection, and trying to prevent that, but also will worry about Clostridium difficile disease or infection. And we know that with Clostridium difficile infection, that one of the main factors is inappropriate antimicrobial use. So if you're using an antibiotic for asymptomatic bacteriuria because that urine looked really turbid or had sediments, and someone ordered a urine culture and then someone gave antibiotics, and then see this happens. So there are stakeholders that can support your work. I talked about the urologist, the hospitalists. They are the captain of the ship. They don't want the patient to stay longer. They don't want the patient to be harmed. So you can work with them, showing them that the infectious and non-infectious complications can be prevented if we don't put the catheter unless it's needed. Geriatricians want the patient to be mobile. They want them to be healthy. They don't want injury to that patient. So they're also stakeholders that will support your work. Rehab specialists. If I want to ambulate a patient, can I keep a Foley in while ambulating a patient? It's going to be much harder. So they are also stakeholders. Physical therapists, in addition to rehab physicians, can be your supporters. Surgeons. Many of you deal with surgeons, and you've seen that after skip recommendations to remove the catheter either post-op day 1 or day 2, there was a huge difference in the numbers of those that were kept longer. It's because surgeons now had, their data has been looked at, and they're very competitive, and they wanted they didn't want to look like, not as good as others. So sometimes external pressures can make a huge difference. And this is where you can engage these surgeons that this is going to affect their skip measures. The intensivist can support this work because, the ultimate good for the whole hospital. And also with the ICU, CAUTI rates have been very stubborn to dropping. And I'm going to talk a little bit more about why later on. But we can push the intensivist to evaluate the need for the catheter in patients that are not in septic shock or patients that are hemodynamically stable. Again, in the ED, we have proof it works. We just have to engage their leaders, nurses, and physicians, and we can drop the utilization significantly. So what about those that are not supporting the work? And this is a true story, and you see me here, and that bull was coming towards me, charging, and I had my kids in the minivan, and I fed that bull, and look how nice he is to me. So you can see that you have to figure out, and this was a petting farm, so it's not as bad. But I can tell you one thing, the non-supporters, or what we view as non-supporters, may end up being very, very good supporters to you, and maybe that we're not explaining why we're doing the work. So very important to engage those that are not seen as supporters and explain why they will benefit from the work. And we're doing something to improve quality. So really, if it doesn't make sense, then we have to figure out why it doesn't make sense and learn from it. So with non-supporters, I think we need to make the case for them to, to buy into this and see value. And, if these non-supporters are very tough and they're not able to understand what we're doing, and then we can escalate it to the higher levels, administrative levels. So what about leadership? So that's the role of leadership. Leadership is the one that will give us vision on how we're going to have the effort and how we sustain it. Well, leadership is supposed to ask, okay, so you're doing all this great work. What's going to happen a year from now if, Dr. Smith or Dr. Jones or Nurse Smith or Nurse Jones is not here anymore, who are the champions? How do we make sure the sustainability is there? How do we integrate it in our routine work so we'll continue to excel as a hospital? And also leadership needs to push to get the right people in charge. So the role of leadership is very important. They should not micromanage, but at the same time, they should be supportive. It's related to FTE support or accountability from different stakeholders. So how do we plan for sustainability? Plan for resources. So talk to the teams and figure out what are their needs and how can we make that process very durable. I think a very attractive way to sustain the effort is to build it into your EMR, the electronic medical record, especially if you have something in your facility that's functional. The electronic medical record is very helpful, but it has to be done correctly. So if you plan it in the EMR, it has to be very friendly to whoever's using that EMR. We need to also figure out how to collaborate and build capacity within the institution. So if you have something implemented, how do you make sure that after the implementation you put the effort in it, and then that amount of investment is not there anymore? How do you build capacity to keep that effort functioning with minimal resources? So we plan for sustainability with identifying mechanisms for integration of the process in daily work. And this should be through implementation. When you're putting implementation in, this should be already planned. You would ask team members who will be accountable for sustaining the work. So if I want to know what's happening and if the work is going okay, who's in charge? And who would be in charge for the improvement? These are questions that we need to raise before even we start the sustainability phase. I'm going to give you an example of my hospital and how we did it. And it was, again, through phases. And this is a journey of about 8 years so far. So in 2006, we had a nurse-driven multidisciplinary round approach assessing uric acid need. And, it started with two units at a time. That nurse used to go on rounds with the bedside nurses and the manager of that unit and a case manager, and ask the question, does the patient have a catheter, and what's the reason? So that nurse champion built the question into the minds of the healthcare workers that catheter, if it's there, we need to know why. So it made a culture change. She or he, made the change of the culture on that unit that it's not acceptable to have a catheter without figuring out why. The bedside nurses, were educated on the risk of the catheter and the appropriate indication. And then we looked at the policies in the hospital and made sure the policies are in concert with what are the guidelines. Then we involved the different stakeholders, and I discussed the stakeholders a few slides ago, and involved different departments. But we went from the non-ICU, went to the ED and the ICU. We incorporated at the end the daily assessment of the uric catheter as part of the nurse's daily work, and we operationalized the evaluation of need by having twice weekly, as I said, Tuesdays and Thursdays, we had point prevalence sent to us and linked the work to safety efforts. And you cannot imagine how powerful the third parties are. Say Medicare is very powerful right now with linking catheter-associated UTI and central line associated bloodstream infection with payments to hospitals. But you can link also pressure ulcers because they are related to catheter, immobility, and falls. So this is what you've seen, and this is an older slide. We published this paper about what we've done over the years. We had the nurse-driven removal of unnecessary catheters in non-ICU, and then we had the ED intervention, and then we incorporated, in fact, since 2007, the twice-weekly evaluation for catheters on these units. And we've been having a very low utilization for a very large hospital. These are non-ICU. And then we went and did a survey of nurses, about 230 nurses. We asked the questions, who on your unit is responsible to verify if urinary catheter is needed? Now, if you add up these, answers, you can see that almost every one of these answers has a nurse involved. So nurse caring of patients only be about a little bit more than a third. But if you add it to the nurse caring of the patient, case manager, and nurse manager is about half, and then nurse caring for a patient and case manager is about 16%, ends up being very high, 90% that the nurse is responsible. And then we asked the question, well, how often does the nursing unit evaluate urinary catheter presence and appropriate need? More than 90% said daily. Then we asked the question, well, how often per day? And 83% said all shifts. So it tells me that there's quite a bit of ownership by nursing now, at least in my facility, on device evaluation and need evaluation for use and need. So I painted a very rosy picture. Now, what are the challenges? You can have challenges at different levels, at the individual healthcare worker level and department level. And there are also challenges with our process measures and outcome measures. So I'm going to discuss some of these for the next few minutes. Physicians. So if you hear some of the frustrations, they can say maybe physicians are not partnering. Some of them want to put a catheter in because of, I don't know, it's on the floor. If someone is a renal patient, they want to put a catheter in. If someone is tired and does not want to move around, they may put a catheter in. Well, physicians are data-driven. So if we push for regular indications at the local level, at the institutional level, and have the support of key physician leaders, then it's way easier for us to get adoption. We need to make sure that everyone knows that in hospital X or hospital Y, these are the indications that are acceptable, the others are not. And then it will help us much more with the physicians. Share with the physicians the data. It makes a huge difference when they see that they're not doing as well as others. And have a physician liaison or champion who will engage these physicians. So instead of, someone else dealing with this and having the headache with the arguments, let them peer-to-peer deal with this. And that physician champion will fight for your cause. Nurses, very similar to physicians, it's always how to engage the peer. So get a nurse, and that nurse, he or she will engage their peer, and make sure to explain why this is not going to be more of a work burden for the nurses. And if it is a work burden, how can we mitigate that issue? So show bad cases that happened, and that this is not a harmless device. This can cause bad outcomes and bad harm. Provide some tools to reduce unnecessary use. So, for example, if a hospital needs to look at whether a patient has urinary retention or not, and they don't have a bladder scanner, then it's going to be very tough for them not to place catheter in, or at least straight catheter. So if there is access to a bladder scanner and everyone knows about it, then it's going to be much easier. For males, the use of urinals and common catheters may be also considered. And if someone is incontinent, then bundle some of the work together. So if someone's incontinent and you want to clean them up, bundle the cleaning or skin care with turning every 2 hours, let's say. So it will be one task to be done at the same time instead of having it multiple times and then get the frustration of the healthcare worker. And incorporate indications, placement, and care into competencies. When we looked at that, we had a survey looking at that. We saw very poor compliance as far as competencies. Very rarely would competencies be evaluated in hospitals. So departments, there's a huge effect from ICU to floor. So if the ICU is not helping the floors and they keep the catheter in the ICU when they're transferred out, then they can impact the non-ICU. So work with the different departments to ensure that we have the best outcome all over the hospital, and thinking about the hospital as one part, not the unit as the main entity. So what about process? So we've worked very hard, and we look at our data. Should we look at the appropriateness of use or reduction in use of the catheter? Now, these are process measures. So the final outcome is catheter-associated urinary tract infection or catheter harm. So if we look at appropriateness or we look at utilization, they're both process. But from my standpoint, I would start thinking, well, if the catheter is not there, then the harm is not there. So if we look only at appropriateness, and the appropriateness is 100%, but the reduction in use did not move, then have I done something to improve the care for that patient at risk? It is really tough because appropriateness can be subjective. So someone can say, in the ICU that the patient needs, input and output, as a nose. But the patient doesn't need it. That is part of the indication. So if it's not very well clarified, it will still look appropriate. And this is probably one of the reasons why we're not budging at all as far as our utilization in the ICU. So I'm a fan of looking at reduction in use. So I'm going to give you this example. So you have a baseline of 1,000 patients, patient days, and that baseline period had 200 catheter days. So you have a urine catheter prevalence of 20%. Let's assume that 40% of these days, urine catheter days, were inappropriate. And then what you do an intervention, and you cut the inappropriate urine catheter days by 20%. So if you calculate for pretty much the same population over time, then you'll have, you'll drop the urine catheter prevalence you'll drop the urine catheter prevalence by 4%, to go down to 16%. So let's say the same baseline, and then you have a much stronger population, and with that much stronger intervention. And with that intervention, you cut down the inappropriate urine catheter days to 10% of those. So it was 80, it goes down to 20. So if you calculate this, you drop your urinary catheter prevalence to 14%. So it is intuitive that if you are intervening to improve appropriateness and reduce inappropriate use, you should drop the urinary catheter prevalence. So you intervened, you've shown marked improvement in appropriate indications, but no significant utilization issues. You didn't change your urine catheter utilization. What are possibilities? So either your whole population has changed, so you got, a huge number of old guys right now with prostate issues that had Foley's in, or neurogenic bladders in females, or there's an issue with your documentation. So you were labeling cases as having appropriate indications, although they're not. So that's why I think it's very important for us to see an improvement, a drop in utilization. Now, let's assume you're very successful, you reduce urine catheter use, and you improve proper placement and maintenance. You're doing every single thing by the book, but you still have very high CAUTI rates. So what does it mean? So the possibilities is that with improved use, you have a high-risk population that's selected. So those that are those that still have the catheter are very, very high-risk patients. They have a high risk for CAUTI. So your denominator is smaller, but that denominator, the risk is higher, so your numerator starts going up. Or there's a change in the practice that you are having in your hospital, because CAUTI rates are very susceptible to certain things such as urine culture, obtaining urine cultures, how often you obtain it, and I'll share that with you. So let's say you're very, you're looking at this very closely, and because you're so careful, you're starting doing urine cultures without the need. So let's talk about the first item, so the NHSN versus population-based CAUTI rate. The NHSN rate reflects the risk related to the insertion and maintenance of the catheter. It's very helpful where you have no significant change in urinary catheter use over time, because it will reflect a little bit more introduction of bacteria into the bladder or any issues with opening the urinary system. In the non-ICU, it may not be as effective if you have a huge change in utilization. In the ICU, if you're not making any change over time and you're not dealing with any change in urine cultures, then I think it would be very helpful. So we looked at population CAUTI rate, and what it is, it's using patient days as a denominator instead of catheter days. And I think it's helpful to use it in addition to the NHSN rate and see any difference over time. What it does, it gives you a risk assessment for CAUTI for the whole population. So if you do a very good intervention where you cut the utilization, it will account for that. And if you calculate the population rate, it's really, if you mathematically calculate it, it is the NHSN rate times the utilization ratio times 10. So if the utilization ratio drops, your population rate will drop, even though the NHSN rate is still the same. A couple of things about the NHSN rate. It's probably the best definition that we have right now out of many definitions that are all limited. We don't have an optimal definition for CAUTI right now that we can use for quality improvement projects. So there's a surveillance definition. It's very dependent on having a positive urine culture and fever. And when we look at these cases, most of the cases, more than 90% have fevers. So this is the algorithm, the NHSN CAUTI algorithm. If you see, it's at least one of the following: fever, suprapubic tenderness, or costovertebral angle pain or tenderness. Well, suprapubic tenderness and costovertebral angle tenderness are very rarely documented. So it ends up being most of these cases have fever, and then you have a positive urine culture, and then you get the CAUTI. So what is the problem with the NHSN definition? Well, we looked at our hospital. We looked at the clinician-documented CAUTI. So regular physician, not infectious disease physician, regular physician put the diagnosis catheter-associated UTI or urinary tract infection with the catheter being present. And then we looked at the NHSN CAUTI rate, and we looked at the infectious disease impression. And in our facility, we have one group, a very homogeneous group of infectious disease physicians, and they practice, they're not liberal with antibiotics. They're very strict. What we found out is that the NHSN definition had a very poor positive predictive value of physician practice or infectious disease physician practice. So if you look at the NHSN CAUTI, it was about half of those that are the physician practice. It reflected half of what the regular physicians thought was CAUTI, and even less, 35% of those ID physicians. Very poor positive predictive value. So again, very dependent on fever, and very few patients with the NHSN definition, less than 5%, had one or more focal signs or symptoms documented. So the key points here is make sure that, so I'm going to talk a little bit about urine cultures. So if you do urine cultures in that situation, it can affect your NHSN rate, because you just need a urine culture and fever. So if you do a lot of urine culture if someone is asymptomatically colonized, then you will increase your CAUTI rate. So key points related to obtaining urine cultures: make sure that the clinicians are aware of the appropriate indications for urine culture, and point out the risk of indiscriminate urine culture use on patient outcomes. And I think we should improve the culture of culturing. So you address the local culture or practice of clinicians at your institution to align it with the optimal patient care. So the last thing is to avoid ordering cultures unless clinical assessment of patient condition. This is a document that you can access from on the CAUTI. This is a document that I created for Ascension Health Hospitals, and this has been shared with the national team. And it talks about where to discourage urine culture use and where it's appropriate to do a urine culture in catheterized patients. I want to give some time to questions, but what I would just talk about in a couple of minutes, if you have the same prevalence of bacteriuria, and at the same time you start making a change in the fever pattern. So for those that are infection preventionists, if you look at your CAUTI rates in December and January when you had the influenza epidemic, you're going to notice a spike in your numbers. And the reason is, if you have an increased prevalence of fever in your units in ICUs, people tend to do urine cultures. And what will happen is if they have bacteriuria, then you have more cases. So this is an example of the fever relationship with NHS and CAUTI. At the same time, if you're doing more urine cultures, and keeping the others constant, you will have an increase in CAUTI. So finally, what's important is to remove the catheter, not to use the catheter unless it's needed. If you have a catheter in someone who's asymptomatic, do not do urine cultures. Cloudy, odorous urine or sediments do not mean infection. Because if you do the urine culture and it comes positive, then someone's going to start antibiotics, and then the inappropriate antimicrobial use will lead to more resistant organisms and patient harm, such as Clostridium difficile. So no catheter, no unnecessary cultures, and no CAUTI and patient harm. The last slide, to sum it up, know your catheter, collaborate between disciplines, have champions for accountability, look at data and let data push your work to improve, and incorporate catheter evaluation into the routine, work routine, so have a sustainability plan. Thank you.
Thank you, Dr. Fakih. That was a wonderful presentation. It you hit on a lot of the challenges I think we're having in clinical practice right now. I know you talked briefly about your document that you made for Ascension Health. It's on. I just want to share with everybody. It is on the CAUTI, and it's principles of highly reliable care, improving a culture of culturing, avoiding unnecessary urine cultures in catheterized patients. And Dr. Fakih has kindly agreed that maybe we can just share that over our listserv. Eileen, do you want to go through some of the questions that are posted?
Sure. By whom? And if it's initiated by an LIP, licensed professional, is it a default order for all urinary catheters?
I barely can hear you, so is it, I can read it probably. How is the nurse-driven protocol initiated and by whom? Is it initiated by the licensed infection preventionist, is it? As a default order? Well, I can tell you what we have at my facility. Can you hear me?
Yes.
Okay, so the initial work was not integrated into the EMR. And it was nurse-to-nurse, engagement. Now, for the last year or so, what we have a built-in algorithm through the electronic medical record, where initially, when you write an order for, or when you put an order for a Foley, the physician needs to explain why. So he or she needs to enter why the catheter is placed, appropriate reason. The next day, there would be a trigger coming to the nurse caring for the patient on the utilization of the catheter, and the nurse, again, needs to decide on whether there's an appropriate indication or not. And there's an algorithm. If there's no appropriate indication, then the nurse can discontinue the catheter based on that algorithm. This went through Medical Executive Committee and was approved in our system, St. John Providence system. Is that what was looked for?
Yeah, if that didn't answer Judy's question, she can come back on chat if she needs additional questions. I did want to share with a slide to be shared. Yes, we will send the slide set out again to all our participants today. But I do have a question for you, Dr. Fakih. I know that Diane over at MPRO, we've talked to NHSN, the contact experts over there quite a bit about this CAUTI issue related to fever. Not only fever, but when they're culturing, they're finding a lot of fungus
Candida.
Candida in their urine culture. So they sort of alluded to help is on the way for this NHSN definition, and they alluded to a work group. Is there anything you could share related to that, or not really?
Well, I'm not part of the work group, but what I can tell you is my understanding is there's minimal changes in 2015 that will happen. My issue was removing Candida, so some of the questions were, okay, it's not clinically relevant, Candida should not be treated in the urine. My worry, if we remove Candida, then what we're doing is we are really encouraging hospitals that use a lot of antibiotics to continue using antibiotics. So for me, an increase in candiduria means that a lot of antibiotics has been used in that unit. And I see it also as a quality improvement, a quality measure. You know how I feel about the CAUTI definition. I think it has a lot of limitations. But my worry is if we remove Candida, it may even make it more limited and not reflective of what happens in the unit. Because we know right now it's not reflective of true catheter-associated UTI.
Correct. I understand what you're saying. Then what would you suggest maybe a better strategy would be? Basically maybe looking at our culturing patterns and, inappropriate culturing? I mean, I think...
Right. So for outcome measure, I think, honestly, for the outcome measure, it should be all harm, and the best surrogate would be utilization, urinary catheter utilization. Another thing to consider is if we want to stick to the CAUTI as an infectious, again, the definition still the limitation is still in the definition, but population CAUTI rate, I think, is a better description to what we're doing in our hospitals as far as quality improvement, related to CAUTI reduction. As far as culturing stewardship, improving the culturing decision. And I didn't have time to talk about this, but what needs to be, and I think it's a very important process measure, and it's going to affect your culturing difficile rate. I think we need to make sure that no reflex cultures. So I was in two hospitals very recently where they had triggers for urine cultures based on any abnormality in a urinalysis. And you know how often we can have an abnormality in a urinalysis. So that pushes for quite a bit of urine cultures and a large number of positive urine cultures and a lot of antibiotic use that's inappropriate. So I see this as part of the antimicrobial stewardship. Culturing stewardship is part of the antimicrobial stewardship. If hospitals want to look into it, the first thing they need to do is go back and see how many of their standing orders or order staffs have integrated cultures that are either reflex cultures or routine cultures that are not meaningful.
Thank you. That's really helpful. I think everybody's challenged with, increasing CAUTI rates, and, they've done everything they possibly can, but I know that the outcome measure basically is not necessarily patient risk adjusted, and really there are no exclusion criteria. It's simply a surveillance criteria. So it is kind of sometimes problematic for a lot of our providers, especially in view of the fact that they're utilizing it for a lot of pay-for-performance initiatives. Thank you for Yeah, thank you for your insight on that.
Mm-hmm.
Operator,
Diane, Judy did follow up in the chat.
Okay, great.
Dr. Fakih, can you read that?
Oh, okay. Let me read. Yeah. So, how is the EMR used to initiate the nurse-driven protocol when a catheter is ordered by probably licensed individual practitioner? Okay. MD, nurse practitioner, PA, does this automatically trigger the nurse-driven protocol? And that's what I tried to explain. So the initially, and this is again locally in our system, what we have is the first order, the LIP would specify why the catheter is placed. Okay, and then the next day, in morning shift, the nurse who's taking care of the patient will have a trigger to respond to as far as whether the catheter is needed or not, and he or she needs to place the reason for continued use. If there's no reason, appropriate reason, so these are all stuff that the nurse will click. So nothing text. If there's no proper reason for continued use, then it will trigger a discontinuation of the catheter without physician order. Now, we had some glitches initially, and what we did is, if anything is ordered by urology, this algorithm would not be active. Okay, so for urology, it's excluded because we had some events initially where catheter could have been removed, was removed without the urologist being involved. Does this explain it?
I believe it does. Thank you.
Thank you so much. Yep, I can see it's the top of the hour, and just to be mindful and very thankful for Dr. Fakih for speaking today. I think we have no additional questions. Judy said thank you too, so I think we're all set. I would like to just thank everybody for participating today. We will be doing some follow-up with some polling that will be put up shortly. If you could answer the polling questions, we'd greatly appreciate it. Thank you.
Okay, bye-bye.
Bye-bye.